Hi, guys, it's Dr. Sadaf, and I just wanted to give you an update as to what is going on. So, I have opened up my practice in Chappaqua, New York, and I'm currently accepting new patients. So, I want to invite you to come and become a patient of mine. If you've been listening to this podcast, you've been listening to the episodes, you are finding so much value in all of this. I want to invite you to become a patient of mine and come see the difference with a doctor that actually has time to listen to you and support you through the transitions that you may be experiencing, whether they're perimenopause, menopause, or you're experiencing any type of sexual dysfunction. And of course, I do annual GYN exams as well. So if you're not having any problems at all and you just need a regular exam done, I am more than happy to help you out. So make sure you check out the practice. It's called FemV Health, and the website for that is www.femvhealth.com. And make sure you look that up. The phone number for the practice is 914-538-2534. And make sure that you go and check it out. Check out the website and make sure you book your appointment today. Also, I have just started a new Facebook group. It's called It Might Be Menopause Support Group by Dr. Sadaf Lodi, FemV Health. And I'd love for you to come and join that Facebook group, because in that group, we'll be talking about different ways that you can get support and education as you go through this important transition in your life. It's also about building a community that is going through the same things that you are. Oftentimes we feel that when we go through things in our life that we are the only one, but I'm here to tell you that you are not alone, and that there are so many other women going through the same symptoms that you may be going through, whether it's hot flashes, night sweats, mood swings, vaginal dryness, pain with sex, brain fog, joint pain, dry eyes, any of those things, so come join us in that Facebook group. It's called It Might Be Menopause Support Group by Dr. Sadaf Lodi, and that's on Facebook. So come and join us in that community. And I definitely look forward to welcoming you there. And make sure that if you have any questions about any of the podcasts that I do, that you either DM me or email me, and I will create a podcast just for you, because you are a loyal listener and subscriber, and I would love to answer any and all of your questions. So if you have any burning questions that you are wondering about, please make sure that you email me at hello@femvhealth.com and let me know about your questions, or DM me on Instagram or TikTok, and I'll create an episode just for you. And as always, make sure you like, share, and subscribe to this podcast. As you know, I am looking to get over 100,000 downloads by the end of this year, and I'd love for you to help me out in that endeavor. And so please share and like these podcasts, download them, and let all your family and friends know, because I know there is not much information out there, and some of the information out there is not actually factual. So you want to make sure that you are getting your medical information from a board certified OBGYN that knows and has studied all of this material, whether it's sexual medicine, perimenopause, or menopause. So looking forward to hearing from you. And now to the episode. I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf Lodi, and this episode is everything you need to know about maternal mental health and all the things that go along with it. But before I get into the episode, a few things I want to make very clear is that, one, I'm definitely not giving any type of medical advice. So if you have any issues with your mental health, or if you're suffering from depression or anxiety, or any of those things, please seek out a mental health care provider, because they are the best ones to help you out. And I'm definitely not giving any type of religious advice. If you have any questions about your religion, make sure that you go see your friendly neighborhood religious leader. This is the Muslim Sex Podcast, because I just happen to be a Muslim woman that talks about sex. So I am super excited to have on with me today Dr. Anna, is it Glezer or Glezer?
Glezer, yes.
Glezer. Okay, I just want to make sure I say the name. Throughout my whole life, everybody's always said my name wrong. So I always try to make sure that at least I get other people's name right. So I'm so excited to have you on. And if you don't mind introducing yourself to the listeners and viewers out there.
Absolutely. So thank you so much for having me here today. I'm really excited about this conversation. And I am a reproductive and integrative psychiatrist. And for those that might be somewhat unfamiliar with what all those words mean, reproductive psychiatry is the field of psychiatry that deals with mental health across various reproductive stages. So it could be preconception, fertility journeys, pregnancy, postpartum, perimenopause, premenstrual symptoms, really whenever hormones play a role in mental health. And then the integrative psychiatry piece really just refers to an approach that is comprehensive and holistic and really takes in both conventional treatment tools as well as things that might be considered more complementary and alternative, and kind of puts them together into comprehensive plans for our patients. So I'm a reproductive and integrative psychiatrist. I've been in private practice since 2017. I also teach at UCSF, and I have several other pet projects to really just focus on educating both clinicians and patients and the general public about issues that relate to reproductive mental health.
That's fantastic. Wow. I didn't know you were a professor at UCSF. That's fantastic. So yeah, I mean, I was, you and I were speaking a little bit offline just before this recording started, and I wanted to go over a case with you that actually I just saw last night. I was on call, and we had a lady that, she's a 48-year-old woman that had been trying to conceive for so long. Hence, she's 48 and she's still trying to conceive. And she was pregnant with an IVF pregnancy. This was her first pregnancy that actually took, and she had multiple surgeries before this for fibroids. And so she came in, and unfortunately, she had miscarried. So she was 19 weeks now, so pretty far along, and she had miscarried at home. So she delivered the fetus at home, and then she came in, and she was bleeding and bleeding and bleeding. She wasn't initially bleeding when she came, but then she started to hemorrhage, and then we went and we took care of that. She bled quite a bit, actually, but my concern, aside from obviously, making sure that the woman, that she was stable and that she was medically clear, is just the mental health trauma that she just experienced and went through, right? So she had been going for so long with these IVF treatments and, trying so hard. And finally, she got pregnant. And every time she had a surgery, she had some complication with that surgery, unfortunately. And so now she finally got pregnant, and here she is, she ended up delivering. So I'd love to hear from you. What are all the things that a clinician, say, for example, her OBGYN or maybe her family doctor, whoever sees her next, what are things that they should be kind of on the lookout for?
I think one of the main things to think about is what has this patient's journey looked like? Because a fertility journey can be very, very prolonged and have a lot of ups and downs. It's very much a roller coaster, right? There's, periods where you're kind of going up the hill of that roller coaster, and there's, hope and optimism. And then unfortunately, there's oftentimes many instances where the roller coaster goes down and there's various kinds of setbacks, whether it's, a failed transfer, or whether it's insufficient egg retrieval, or whether it's a loss, first, second trimester loss, or whether it's a setback in the form of, needing another step or another surgery for fibroids or endometriosis or whatever the case may be. And so kind of being able to see the fact that this is a roller coaster in the patient's life, and that means it's a psychological roller coaster with that hope and that optimism, and really allowing the patient to have the emotional experience after this kind of, trauma, essentially, that took place, where there's time for the person to grieve that loss, but also to make sure that the person, because one of the things that can often happen throughout this kind of journey is there can be a lot of self-blame, and a lot of questions are often asked of the clinician, did I do this wrong, or did I do this wrong that led to this particular outcome? And so I think one of the things for a clinician to really keep an eye out for is, is there any of that kind of self-blame? What kinds of questions is this particular patient asking, in order to make sure that, that kind of self-blame is not happening right now, and to kind of cut it off if it is, by providing reassurance that, no, the fact that you went for a nice run did not cause this miscarriage, or the fact that, whatever it was that you might be blaming yourself for did not lead to this particular loss. So allowing them the space to kind of process their grief, making sure that there isn't some of that like blame and self-blame, and making sure that the other piece from like a fertility journey perspective is that a lot of times, because it's so involved, right? It's so many different appointments. It often can feel like it's taking over a person's life. And so the other thing that I like to do is to really encourage patients who are going through this experience to make sure that their other identities are also still being engaged in. So making sure that whatever else they still have in their lives, whether it's their job, their partner, their friends, that they're still engaging in other aspects of their life, so that their entire identity is not necessarily wrapped up in just this fertility journey, that their other identities are still being maintained. And so the grief, the self-blame, and the identity piece, I think, are three important psychological experiences to just keep an eye out for as the clinician. And then for this particular case, I mean, it sounds like it really was traumatic, right? Yeah. And so the other thing to keep in mind is, what are the different signs and symptoms of someone who might be having a post-traumatic stress episode, yeah. Right? So, are they having trouble sleeping? Are they having intrusive thoughts and memories? Are they feeling like their physiology is just on edge, that they're just always hyper vigilant, hyper aroused, that their, small things kind of set them off? We're having episodes of anxiety and panic. Like, is there a post-traumatic stress kind of picture as well, given the trauma that this particular patient went through?
Wow, I think you brought up so many good points. Definitely the grief and the psychological roller coaster that she went through just to become pregnant. But I think you bring up a very good point of this post-traumatic stress, right? That's something that we don't always think of. We definitely, like I was thinking of, postpartum depression, postpartum blues, all of that. And, definitely anxiety is up there as well, postpartum. But, the PTSD part, I think it would be a really big component that sometimes can be missed because, if I think about how she presented, right, she came in via the ambulance and she came in through the ER and she had already delivered at home and came in, all bloody and things like that. And then, comes over to postpartum and then she hemorrhages more. And then we take her to the operating, it's just a lot of stuff. And then, her blood pressure drop, all this stuff, right? All this crazy, scary stuff for not just the patient, but also the clinicians, right? Because we're trying to save her life and making sure that she doesn't bleed to death. So all of that, I think, is a very good point that you bring up. And definitely, I think that patient will need grief counseling, but also have to deal with all of this trauma and then, think about what she wants to do in the future in terms of her reproduction, just because this is something that she really wanted, right? And I think the other physician that was with me on call had, because it was her patient, had spoken to the patient's family about whether or not, she wants to, is she going to try again? I mean, she's 48, so it's really difficult at that age. And that perhaps she should consider like a surrogate or even adoption, right? Because we know there's so many children that need adopting. So anyways, that was just a case that came up and it just happened last night. It was super fresh. And I thought that I would, present it to you and see what you thought, since you are the perfect person to discuss this with.
Yeah.
So, I'm also curious about, we talk about, so for somebody, let's say we can just continue on this case. So let's just say that, this patient is recovering 6 weeks out, whatever, and she has a hard time connecting with her partner, right? And then she presents back to us, and this is all hypothetical now, but, and she says that she's not able to connect and they're no longer able to become intimate because of not only the PTSD, but, that she's just not interested anymore and things like that. What are some things that you would, consider? Because we know, and for those that have listened to my podcast before, know that I always say that the brain is the biggest sexual organ. And so if our brain is not really into whatever it is that we're doing, it could be anything, right? It could be like your work, exercise, whatever it is, whatever. If you're not really into it, you're not going to enjoy it and you're not really going to want it. So, what would you say to that person?
I completely agree. I think that there's such an intricate relationship between our mental health and our brains and our sexual health and well-being. And you really can't you can't unlink those. And so I think with this particular patient, it really does sound like there's a lot of mental health directions that need to be addressed so that she can feel reconnected. And some of that probably needs to be individual work, and some of that could also be work that they do as a couple. And I think, because there's so many psychological aspects to the intimacy in the context of a fertility journey, right? Kind of going back to that piece of, identity and feeling like, the conception almost becomes like a job as opposed to the experience, the sexual experience being something that is for its own sake, pleasurable and enjoyable for the individuals. For this particular patient, I would imagine that there, again, could be some of those elements of self-blame, and there could be, some of those elements of trauma that can really take away from that, that feedback loop that's required for someone to actually have a pleasurable sexual experience and intimacy. And if you're sort of taking away the desire and someone's mind is distracted by their PTSD symptoms and their anxiety and the what ifs and all of that kind of thing, it's going to be really hard to connect with your partner. And I really would also wonder, what is the relationship that she has with her partner, the context of, in addition to self-blame, is there anything that's going on where, is there anything related to blaming the relationship or blaming the partner, right? Like our brains don't necessarily do this rationally. These aren't rational things that happen, but this is just how our minds work sometimes. And so I think really addressing all of those psychological challenges and hurdles that she might be having individually, and then also doing the partner work, really just making sure that the partner is also very well aware of whatever is going on for this particular patient individually and can kind of bring that support and kindness and compassion into the relationship to allow for more intimacy. So it's both individual work and work that they would do as a couple to kind of improve that intimacy. And it's not necessarily something that's going to change overnight, right? It's going to involve some time and investment.
Absolutely. So, I'm curious to know, would you ever use cognitive behavioral therapy in something like this? Would you focus on what the thoughts are and then try to get to change those thoughts to, which then, of course, we know lead to feelings, which then lead to action. So would you start, initially working on whatever negative beliefs or thoughts that she was having to try to help her to change that? And how would you go about doing that?
So cognitive behavioral therapy can be a really great tool, especially if someone is having a lot of negative self-talk, negative kind of general blame, negative thoughts about themselves, the experience, the future, the what ifs. It can be really helpful for managing anxiety symptoms. But there are so many other different psychotherapies and different styles of therapy that could be helpful. So particularly if we're talking about trauma, there's a lot of different trauma-based psychotherapies that could be really helpful depending on how someone is navigating their traumatic experience. So for example, for this particular patient, if she has a lot of intrusive thoughts and memories of the experience of, worrying, am I going to die because I'm bleeding out because of, how serious this is, then there's a lot of different things that can be done in terms of therapies like accelerated resolution therapy, which is basically an eye movement derived therapy that helps tease out the emotional valence of an event from the actual declarative memory of the event. There's other kinds of trauma-focused therapies like somatic work, which really helps someone reconnect with their body. There's exposure types of work. There's narrative-based works. There's lots of different kinds of trauma-informed and trauma-focused therapies that can really help someone process this kind of event. And so it really depends on her individual psychological goals, right? If she wants to really process the trauma, then some of those kinds of therapies could be really useful. If she really wants to focus quite a bit on some of the negative thoughts, then CBT is great for that. And then, if she really wants to work on the relationship with her partner and do couples work, then there's lots of different couples focused therapies that could be useful, emotionally focused therapy, or therapy that really focuses on the intimacy as well.
That's great. So when you talk about somatic work, and perhaps you can explain a little bit to our listeners and viewers what you mean by that.
So somatic therapy really helps an individual connect more with their body and where different sensations are happening in their body. It's sort of like a mindfulness-based experience. And I think one of the things that sometimes happens, especially for some of our patients that might really be, really smart, accomplished people who kind of get stuck in their own brains and they sit a lot in their heads. They don't really pay attention to what's going on in their body. And their body might be experiencing a lot of trauma. And so they might just kind of always be tense and not sure why they're waking up with back pain, where it's really all of this tension that they're just kind of holding and not noticing what's going on in their body. This type of therapy really allows someone to get out of that spin in their heads and really focus more on their body and their relationship with their body. It's sort of a mindfulness-based type of experience.
That sounds really helpful. I think definitely, especially after experiencing trauma, I think people like to disassociate, right, from their bodies and what happened to their body as opposed to, what they can try to control with their mind. And I think that really probably is a very important modality to help people reconnect with their own bodies. So that sounds like something that I think would be very helpful for individuals that experience trauma, such as this. So, I'm also wondering and curious about, you talked about like the journeys hormonal journeys that women take. And you're absolutely right. There's so many different, hormones that we focus on, and especially, the perimenopause, menopause timeframe. And as our estrogen kind of goes up and down during that time. It's almost similar to puberty, right? Like where our estrogen is going up and down. And then, there comes a time when the estrogen really declines, right? And it goes down, let's say it goes down to zero. A lot of women during that time will experience a lot of anxiety, new onset depression, the brain fog, all of those things that has to do with the decline in estrogen. But I think a lot of clinicians are not aware of what happens during perimenopause, menopause, and so end up prescribing like SSRIs or, antidepressants for women, instead of realizing that perhaps it's the decline in the hormones that's causing this. Do you see a lot of this? And how do you help clinicians to realize what actually is going on?
Absolutely, all the time. I definitely see a lot of this. And this is part of the reason that I do some of the clinician-focused educational work that I do to sort of teach. Even psychiatrists, I think, also need to be aware of this because patients are often sent to see the psychiatrist, because they're having some of these mood swings and brain fog and some of these common mental health symptoms during the perimenopausal transition. And so part of what I want to do is make sure clinicians are aware that these are actually really common symptoms of perimenopause. It's not just night sweats and hot flashes. And really the psychological symptoms, in addition to oftentimes some of the body recomposition symptoms, tend to be the ones that patients complain about the most, is most like functionally impactful, right? If you're having, mood swings, and irritability is a common way of describing some of those mood swings. If you're having an increase in your anxiety, because a lot of women really are very sensitive to the delta, the hormonal change, right? It's not the absolute number, it's the change. And that's why, individuals who maybe were previously vulnerable, maybe they had more significant premenstrual symptoms, or maybe they had postpartum symptoms. Again, when the delta becomes significant because of that hormonal drop, both premenstrually, postpartum, and then of course in perimenopause, those who have a sensitivity to that change are going to be more predisposed to these kinds of psychological symptoms. And so there's, 50 different symptoms of perimenopause, but your average patient probably is aware of 3, and your average clinician maybe is only aware of 4, right? So we need to make sure that everyone is aware of the fact that it can be very, very heterogeneous. You could have 3 women going through this experience, and they all look very, very different. And so I think, yes, there's evidence for SSRIs in managing anxiety and depression and sometimes vasomotor symptoms. But you also want to think about, what is the root cause of all of this, right? Because if you have someone who, maybe they're taking an SSRI for their anxiety, and then they're taking, a statin for their metabolic shifts, and then they're taking pain medication for their joint pain, and then they're taking, a bisphosphonate for their bone health. They're taking all of these different things without necessarily thinking, and seeing 4 different specialists for each of those things, without necessarily thinking about, what is the root cause of all of this? And can we address that root cause in a way that helps support this particular patient?
Right, absolutely. And definitely there, women will, in their perimenopausal period, a lot of women will become insulin resistant, right? And so we'll see this new onset of pre-diabetes, diabetes, all of this stuff because, there's decreased estrogen and decreased insulin resistance. But I think a lot of clinicians, are not aware because we just don't get the training. I don't know if you got training, but I definitely did not get training in medical school about perimenopause, menopause, any of that. And so because of that, I think there's just such a huge void in our knowledge about, this really important transition, a transition that women will spend approximately a third of their lives in. And it's unfortunate that most of us clinicians don't know that much, right? I mean, I think there is definitely a huge change. The North American Menopause Society at the time of this recording is going on in Chicago. And I was actually too late to sign up. I mean, it was full. Their capacity was 1,500 and they reached that. And so there's a lot of people. I'm doing it virtually. But I think that it is definitely shifting. People are really, as we are moving as clinicians, as the younger generation clinicians are moving into perimenopause, menopause, I think that we are taking a newfound interest, right? And we want to make sure that as we get older, that we are aging gracefully. I think not even just gracefully, but I think more like we just want to be strong. We don't want to be frail. We don't want to be losing our memory. We don't want to be having this genital urinary syndrome of menopause. We don't want to be, taking all these medications for all these different things like you just mentioned. Instead, just take one medication, which is probably estrogen that you probably need. And I don't know if you're familiar with the book by Dr. Lisa Mosconi. She's called The Menopause Brain. And
Yes.
she talks about how, the research that just came out, I think she published it, it's through Cornell, and she was funded by the NIH. But she talks about how during the perimenopausal period, right, you have all of these estrogen receptors in our brain that are lit up. It's almost like they are hungry for estrogen and they are seeking estrogen. And that's probably why we exhibit so many of these, mental health challenges during this time, because our body really is seeking it and we don't have it. So that's why it's really important to see a clinician that understands and knows what's going on during this time frame so they can really help you.
Yes, absolutely. And the North American Menopause Society has, a list of certified clinicians. So if someone is looking for someone in their area, that's a great place to start. And absolutely, we have estrogen receptors in our hippocampus, which is the part of our brain related to memory, right? So when people talk about forgetting where they put things and misplacing things and just being forgetful, word finding challenges, there's so many estrogen receptors in the hippocampus. There's estrogen receptors in the amygdala, which is sort of our emotional and fear-based center. There's estrogen receptors in our cerebellum, which is involved in things like balance and coordination. So there's estrogen receptors all over our brain, and they're not getting the estrogen that they are used to.
Yeah. Yeah. So important for us to realize that, and my family actually just makes fun of me all the time. They're like, oh, does your tooth hurt? Maybe you need estrogen, right? They're like, you give estrogen for everything. But I'm like, no, really, it does. It really is involved in everything. We have estrogen receptors all over our body. I mean, women experience hair loss, the decreased elasticity, collagen, more wrinkles, all of this stuff, right? All because we don't have the estrogen. It affects our bones. It affects everything. And
Yes.
so, I really do think it's so important. And, not everyone's going to want it and not everyone feels like they, need it. But, I had a friend of mine say to me, she was like, well, menopause, perimenopause transition is just like a natural aging. So why not just leave it alone? Why do we need to go on estrogen? And I said, hey, well, somebody getting diabetes, well, why don't we just leave that alone, and let them have this peripheral neuropathy and let their toes get cut off. Who cares? It's just a natural progression of the disease, right? Like, I'm like, what? Like, it's just, we have the treatments, right? Why not just use it? I mean, there is, I recently visited Pakistan. I'm Pakistani. And, I was talking to my cousin who's a gynecologist, and she was telling me that, in Pakistan, they don't have very many lectures on menopause, perimenopause, which is not any different from here, right? I mean, we don't get much of anything either. And she said, most of the clinicians are not treating perimenopause, menopause. And then I talked to another one of my cousins who said that, I had talked to her about estrogen and progesterone and this and that, and she couldn't find it anywhere. And she's in a big city. It's not like she's in a small city. So she's in a big city in Pakistan, and she couldn't get estrogen or progesterone. And I thought, what, that's really sad. Because, these people, like my cousin wants it and she's not able to get it. And, I feel like a lot of times here in the US, we take it for granted that we have so many things at our disposal, that we don't realize how really lucky we are, because we have so much information, social media, so many doctors on social media talking about menopause, perimenopause, all of these changes. But also we have access to medications that can help us and that can change the trajectory, right? If we wanted to, if we decide estrogen is what we want to do, so then, we're able to take it. Whereas there are other people, around the world that don't have access to these type of medications. So I just feel like, we're really lucky out here,
Yes.
we have access so much.
And I really think that the first part to all of that, though, is to know that this is what you're going through, to be able to kind of recognize it, to have that awareness, and to be able to kind of connect with the clinician who's going to help you get that access.
Absolutely. Absolutely. And it's, talking to people like you who are psychiatrists that know that, all of these things that you're talking about, right? This constellation of, psychological symptoms that you're having are all due to the decreased estrogen that you may be experiencing. And, really and that's why I think it's really important that as physicians, we're not just treating like one symptom at a time, but we're really just looking at the root cause of what the problem is, right? I mean, there's women that have heart palpitations, that have joint pain, that have different arthralgias, that don't realize they have frozen shoulder, they have, all this stuff that they don't realize actually kind of goes together, right? I mean, we know that the most downloaded article last year was the one about menopause in the New York Times, and that was that article written by Sue Dominicus, I think, and she talks about her first symptom, which was brain fog. Right. It wasn't the hot flashes. It wasn't the night sweats that we usually hear about, but it was actually brain fog that she experienced, and how she was really just dismissed by her gynecologist, who felt like, she was just kind of whining, and that it really wasn't a big deal, but it is a big deal, because, we know that if women are not able to really concentrate at work, or if they're not sleeping well, or if they're having, this restless nights, then they're really probably not going to take a leadership position. They'll probably, forego a lot of things because they just don't feel well and they don't feel like they could be performing optimally.
And I think there's a lot of data out there on sort of a number of midlife women kind of leaving their professional careers significantly earlier than they would otherwise because of these kinds of symptoms and experiences. And also plenty of stories of women who are feeling like their experience is not validated and they're misunderstood. And oftentimes some of these psychological symptoms do come, well before the vasomotor and other symptoms that people consider perhaps a little bit more traditionally, perimenopause. And so the brain fog and the sleep disturbance and the mood swings and all of those kinds of symptoms. And I think the other thing is, for some people, it's hard to connect. Why would I put together my insomnia with my joint pain, with my gut health? How does that make any sense?
Right.
But yes, it does make sense given the location of all of our estrogen receptors.
Absolutely. Absolutely. Yeah. And I think that it's, Again, I'm just going to get onto my soapbox and talk about how important
Join me there.
yeah, right. And how important estrogen is. And it really is, I think, as we get older, there's very few like absolute contraindications to taking estrogen. And really, talk to your doctor about it. And if it is something that you're interested in and, you really are worried about your heart health, you're, worried about your bones, worried about your brain, worried about really everything. I mean, your vulva, vagina, your intimacy, all of that stuff. I mean, honestly, it's so important to just go and find a practitioner that knows what is going on, that can really help you and really tailor the medication to whatever it is that you want, right? It's not like a one size fits all. It's really just patient centered approach that we use. And, really, if you do nothing else, and I say this to my patients all the time, if you decide to do nothing else, like you don't want hormones, you just want to let it go and do whatever your body does and whatever, that's fine. But one thing you should always take care of is your vulvar health. Absolutely, 100%. And make sure that you take that vaginal estrogen because one, it doesn't go all over the body. It's not systemic. And two, it protects the vulva, the vagina, prevents recurrent UTIs, prevents you from having these recurrent UTIs that can turn into sepsis and can lead to death. So I think it's really important that, we really stress the importance of vaginal estrogen because that is for me almost like a non-negotiable. I don't, it doesn't matter to me if somebody says, I don't want anything to do with hormones. I say that's fine, but please take care of your vulvar vaginal health because that is really, really important.
Yeah, and I think a lot of people don't necessarily recognize also just what you mentioned, the preventing recurrent UTIs and then everything that kind of goes downstream from that, right? You
Yeah.
get a UTI and then you take antibiotics and then, then you're on multiple antibiotics over time and how that impacts your gut health. And there's so many downstream effects,
Right.
which could be prevented.
Right. Absolutely. Absolutely. And so that's why, right, a lot of these things that we talk about are preventative measures. So it's really important to go and talk to your doctor and see what's right for you. And but like I said, if nothing else, make sure you take your vaginal estrogen, put that on. So, I'd love to know, are there any, things that you feel that somebody should absolutely know about, their reproductive health and how that correlates to their mental health? Anything that you'd like for the listeners and the viewers to leave with, to make sure they just understand?
Well, I think that the main thing is that there is such a connection between your psychological health, your hormonal health, your physical health, your sexual health, all of the different kinds of ways that we describe wellness, spiritual wellness, psychological wellness. I mean, all of these things are so closely linked and you can't remove one without having an impact on all of the others. And so I think it's really important to make sure that all of these different types of health and wellness are addressed on a regular basis. Make sure that, of course, you're keeping up with your physical and medical health and getting your screenings, making sure that you're on top of what your hormonal health is doing, making sure that you're focusing on your psychological and emotional health and well-being, whether that's making time for psychotherapy, whether that's making time for social connections, whatever that means for you, keeping up with your sexual health. All of these different things are so integral and you can't really discount one. So that's really the main takeaway is how linked all of these things are.
Yeah, I think that's so important. I was just I was working out the other day, and the instructor, I was doing like a virtual class, and the instructor said, every day she asks herself, what does, and her name is Jess. So she was like, what does Jess need today? And I thought, that's fantastic, right? You're like checking in with yourself. You're saying, all right, today, I'm feeling X, Y, and Z wise. What do I need today? And you kind of look that up and figure out what it is, and then you go seek it out, right? Like maybe it's you need a massage, maybe your body, your whole body aches because you've been up all night delivering babies and talking about myself,
Yeah.
and, uh, and and you just need a 1 hour massage to relax those muscles. So I think that was great, and kind of falls into line with what you're saying about how like looking into each one of your health, right? Your sexual health, your mental health, your physical health, all of this stuff, and seeing what it needs. And I think that we oftentimes neglect our mental health. We just keep pushing through, keep going till we hit a roadblock and just either explode or break down or decide that you just can't do it anymore because you're so overwhelmed.
Yes.
That it's really important to just take care of ourselves and take care of our bodies and our mental health.
Absolutely. And to that point of even just asking what I need, right, is actually something that I think is a bit of a foreign concept for particularly women who are like, okay, well, what does my child need? And what do they need? What does my boss need? And the question of what do I need gets, keeps going lower and lower on the priority list. And we really need to move that all the way back up.
Absolutely. Absolutely. You're right. I mean, we take care of everyone else except for ourselves. And it's really important to start prioritizing that. And so for the listeners and viewers out there, today, I want you to talk to yourself and ask yourself, what do I need today for my mental health? I think that's really important. And so for all of those viewers and listeners out there that are watching you, Dr. Glezer, and they're like, wow, she is amazing. How can I get in touch with her? How can I talk to her about my reproductive and mental health? How can they get in touch with you?
Thank you. I would love to connect. So for folks who are interested in working with me directly, I'm located in California, and you can take a look at my website, which is just my name, AnnaGlezerMD.com. You'll go to Women's Wellness Psychiatry, where we do this kind of integrative work. If you're a clinician and you're interested in learning more about this interface between reproductive and integrative mental health, you can take a look at the online course that I do, which is psychiatryfellowship.com, which is for all comers, whether you're a psychiatrist, OBGYN, pediatrician, any kind of clinician. And you can find me on Instagram. I also do a podcast every 1 to 2 weeks on topics related to reproductive and integrative psychiatry. So lots of different ways that you can find me. And I look forward to seeing you all there.
Amazing. Well, thank you so much, Dr. Glezer, for coming on and for sharing your knowledge. I think this had so many rich pearls in it for all of us, and for those that were listening. And of course, I was here, so I learned tons. But yeah, no, I mean, really important. And I think that reproductive mental health is so important. So thank you so much for all that you do. It's really much appreciated. And I know that all the OBGYNs out there really appreciate what you do. So thank you for doing that.
Thank you so much for having me.
And well, we are done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you have any questions about your mental health, make sure you go speak with a mental health provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.